So I think with increasing evidence and interest in PRRT through institutional and international experiences and results, I think moving forward to the future, we're certainly expecting a lot of new developments in the field, including both clinical as well as preclinical areas as well. So peptide receptor radionuclide therapy, as you all know, involves a radiolabeled peptide targeting peptide receptors, and typically somatostatin receptor type 2. So there are three main components that make up PRRT. Firstly is the radionuclide. Secondly, the chelator, which is like the linker. And thirdly, the peptide. And these are some of the clinically available agents available at the moment. So some of the new approaches would include further personalizing treatment using what we already have with lutetium and yttrium. Of course, there are new upcoming developments, including the new theranostic pair, copper, that Rod has briefly touched on before. So using copper, we also introduce a new chelating agent called sarcophageine here. Potential use of alpha emitters, somatostatin receptor antagonists, JR11, as opposed to the conventional somatostatin receptor analogs. And also the potential to use PRRT in combination with other treatment modalities to further improve therapeutic outcome for patients. So in the next 25 minutes or so, I'd like to give you a very brief overview of these topics that's listed here, including personalization of treatment, potential new developments, combination therapy, ongoing and upcoming trials, as well as the use of PRRT potentially in other malignancies. And of course, bearing in mind that some of these topics will be discussed in much more detail in the upcoming Theranostic Congress in the next few days. Now, so firstly, personalization of treatment. Now, almost universally in many departments around the world, when PRRT is given, as Rod mentioned, is given as a standard protocol, typically using lutetium-177 dotatate, given over 3 to 4 cycles with a fixed activity of 7.4 gigabecquerels. And this is really based on empirical data. But let me show you two examples. So the first patient here, patient A, has multifocal, small volume bony metastatic disease with very high somatostatin receptor expression, suitable for PRRT. Patient B, however, has a very large, dominant, unresectable primary pancreatic lesion with multiple liver metastases. So really the question is, if we give these two patients a same standard protocol, do we expect an equal outcome between both patients? Because clearly the disease distribution and size is very, very different. Lutetium-177 is typically the radionuclide of choice, but yttrium is also available. So which radionuclide should we choose and when? As you all know by now, Rod and also our team here in Pediatric, in the PRRT team, we're quite strong believers, and Rod has a vision of personalizing treatment instead of using a standardized protocol. And Rod mentioned that one of our recent studies have shown that NET with bulky disease, with lesions greater than 5 centimeters, so pretty similar to patient B here, actually responds less well to the conventional lutetium PRRT regimen. And that is because if you look at the physical properties, lutetium gives off beta particle range with a maximum tissue penetration of around 3 millimeters, so excellent for treating small to medium-sized lesions. Yttrium, on the other hand, gives off beta particles which is much longer, around 12 millimeters in length. So in theory, it should have a greater therapeutic effect for treating larger, bulkier lesions. However, when you look at previously published studies that had used yttrium exclusively during the induction cycles tend to have a higher toxicity than using lutetium alone. Although these are obviously not head-to-head comparisons, but highlighted are the studies that use yttrium dotatoc, showing that these studies have shown a higher renal and marrow toxicity rate. And that is because the longer beta particle, although it's probably better for treating larger lesions, is also possibly more damaging to kidney and bone marrow. So one of the potential new approaches is that perhaps we can sequence using radionuclides according to the tumor size and bulk. For example, with large bulky disease, instead of using 3 to 4 cycles of yttrium up front, we can use 1 to 2 cycles of yttrium early in the treatment course when the uptake of the bulkiest disease is at its highest, so we can deliver the most radiation into it early. And then we can follow it by using 2 to 3 cycles of lutetium dotatate for treating smaller residual lesions and also to potentially minimize toxicity. And we found that using the sequencing approach appears to be highly effective in these patients. So we looked at our 19 patients retrospective study. All patients had previous progressive disease with bulky lesions greater than 4 centimeters in size. A high proportion of these patients also had poor prognostic factors, including more than half of them had G2 or G3 disease. About 2/3 of these patients had FDG avidity. And looking at the waterfall plot, it is actually very encouraging to see that 63% of these patients, bearing in mind with poor prognostic factors, actually resulted in morphologic response. The remaining patients all had stabilization disease in the setting of previous progression. One patient actually had the largest lesion, reducing by about 73% in maximum diameter, so it's a very dramatic response. This is one of the examples of a patient in this cohort, a 54-year-old patient with pancreatic NET, having concordant somatostatin receptor positive and FDG avid disease. She had 2 cycles of Ytate followed by 2 cycles of lutate with chemotherapy, and at 3 months, as you can see, a dramatic scintigraphic and morphologic response. And this response was sustained up to 20 months after treatment. Another patient in this study, this time a 60-year-old person with high-grade pancreatic NET, who actually had progressed on chemotherapy, came to our department and had the sequencing approach, and at 3 months, again, a dramatic reduction scintigraphically and morphologically. So even the size of the bulky disease had dramatically shrunk. And also results were sustained up to at least 6 months after treatment. This sequencing approach also appears to be quite durable in the response because the progression-free survival was around 33 months. Just to put it into context, although it's not directly comparable, everolimus and sunitinib, which are both currently approved agents for pancreatic neuroendocrine tumor, have a PFS in the order of 11 months. And so really, selection or sequencing of radionuclide according to tumor characteristics may actually be very helpful to further improve patient outcome. So the next question is, how much activity should we give? Again, 2 very different patients here. Patient A has a very high burden of disease with the liver nearly fully infiltrated with liver metastases. Patient B, however, has relatively small volume disease, really confined to the upper abdomen here. These are actually just physiologic uptake in the adrenal glands and the kidney. So the question is again, if we give these both patients fixed administered activity over a fixed number of cycles, do we expect equal outcome between the 2? There's a tumor sink effect phenomenon that has been observed in that the biodistribution of radiotracers is really dependent on the burden of the disease. So we have 3 patients here, A, B, and C. Patient A has a very, very small volume disease. The black arrow there, it's a bit difficult to see, but actually points to a very small lesion in the pancreatic tail with very high uptake. And you can appreciate the normal physiological uptake in background liver, kidney, and spleen. That's labeled S and K. But as the tumor burden increases, like in patient B, and especially in patient C, most of the radiotracers that we administer would preferentially be taken up by the very large disease burden, and less radiotracer would be distributed to normal physiological organs. So in patient C, when we threshold these images properly, you can barely visualize the spleen and the kidney activity, where you would normally expect some physiologic uptake to occur. So in this same study, Jean-Mathieu looked at 10 patients with very variable disease burden and basically found that as tumor sequestration or tumor burden increases, there's also a tendency for the average uptake in physiologic organs like in the kidney and the spleen to correspondingly reduce as well. So a couple of interesting points from this study is that high tumor burden can decrease uptake in normal tissues. Some patient factors, including body habitus and renal function, would also influence the biodistribution. But really the message is that an adjusted activity PRRT regimen versus a fixed protocol should actually be considered for patients, particularly if they have a very, very high disease burden, because it pretty much can allow a high administered activity to cause greater radiation dose to tumor, but without substantially adding toxicity to normal tissues. And on the other hand, if a patient has very small disease volume, we may actually want to give a lower administered activity to prevent from toxicity from occurring. So really, as Rod pointed out before, that patient-specific radionuclide dosimetry is potentially very helpful for patients, for us to try to work out how much activity we give to maximize tumor dose and also to minimize potential toxicity. Ideally, it should be performed for every patient, but it is not universally performed because it is not easily done. It's very complex and it depends on multiple factors. Just a few would include the type of radionuclide that is used. Tumor biology is often very heterogeneous with neuroendocrine tumor and even within the same patient. Uptake and retention can be very different. Patient factor plays a very important role, how radiation can be cleared from the body. And both of these two parameters would really require multi-time point imaging to work out accurately the area under the curve. Typically may include 1 hour, 4 hour, 24 hours, and even up to 96 hours imaging. So it's very labor intensive. And calculation is very complicated, and we certainly need the expertise and the resources to do that. But as Rod alluded to before, that there are image-guided methods, including planar or Q-spect images that can be used to somehow give some calculation for dose verification purposes. But really those methods and calculations are at the moment performed only after the first luteate cycle. And the information obtained is only useful to guide further treatments. And ideally, I think with dosimetry, it should really be taken one step back to do it before the first cycle of PRRT, at the time of somatostatin receptor imaging, to try to work out what is the likelihood of a patient to respond, what's the risk of toxicity, how much activity do we give. But at the moment, prospective dosimetry is very challenging, it's limited, because gallium-68 PET-CT, which is considered to be the most sensitive staging modality, has a very short half-life of 68 minutes. Although it gives very good information about early uptake, it doesn't model lesional or non-lesional retention. So really, to do prospective dosimetry would require an agent with much longer half-life. So there's a new agent or new radionuclide, copper-64, that's now available or being looked at as for PET-CT imaging. So as mentioned, gallium dotatate or dotatate PET-CT is considered to be the most sensitive staging study at the moment, but we can now also label copper-64 with dotatate for diagnostic purposes. And a recent study that had compared these two modalities head-to-head have shown that copper-64 dotatate PET have shown lesions of a much higher target background ratio. More lesions are detected. And one of the advantages is that copper has a longer half-life of 12.7 hours compared to gallium. This is another example from this same paper demonstrating that liver and bony lesions have a higher uptake, targeted background uptake compared to the conventional gallium dotatox scan. And interestingly, splenic physiologic uptake appears lower. So because of this potential advantage of the longer half-life, delayed imaging technically could be performed for prospective dosimetry purposes. However, this paper looked at the use of copper-64 dotatate delayed imaging, which is actually somewhat disappointing, because when you look at the 1 hour and 3 hour images, you can see very high uptake in the tumor within the liver. But on delayed imaging at 24 hours, there's really very poor late retention of copper in the known tumor deposits, and that's probably because the labeling is not very stable. So this really severely constrains the ability to do prospective dosimetry or even therapy. But one of the potential solutions, as Rod has pointed out to before, is that instead of using DOTA as a chelating agent, sarcophagein has been shown to lead to more stable copper binding. So copper-64 can be labeled with sarcophagein octreottate, and short form is called copper sartate. So in preclinical studies, you can show in mouse model here that at 24 hours, there is very high retention of copper sartate uptake compared to copper dotatate. And this led on to the first time in human trial. 10 patients were scanned in Pediatric as a phase 1 study, and this was actually presented at this year's Society of Nuclear Medicine conference in San Diego, showing very encouraging imaging results, and that in 1 hour, 4 hours, and even up to 24 hours, you get very, very high delayed retention of tumor. Another example of a patient who had copper-64 sartate imaging, serial images from 30 minutes up to 24 hours, showing the progressive increase of uptake in these small volume liver lesions. And at 24 hours, there's also significant clearance of the background liver activity as well. There's another patient picture that you've seen before, showing, again, very encouraging uptake with delayed pictures showing ongoing high activity in the liver lesions. So sarcophagy can lead to very stable copper-64 binding. It offers a potential staging technique, at least comparable to that of gallium octreotide PET-CT. The long half-life may give the potential for dosimetry planning purposes. And also, the more important point is that it also has a theranostic pair with potential therapeutic applications with copper-67. So if you look at copper-67, it gives off beta particle, very similar to that of lutetium-177. The maximum tissue penetration range is in the order of 2 to 3 millimeters, so very similar, potentially excellent for treating small to medium-sized lesions. And the half-life is actually quite similar to yttrium and much shorter than lutetium. So really, there's a very good potential for copper-64 dosimetry, followed by copper-67 therapeutic study, which should be underway shortly. So moving on to JR11's somatostatin receptor antagonist, which has a high affinity for somatostatin 2 receptors. So conventionally, somatostatin agonists like octreotide, dotatate, which we're all familiar with, it actually binds onto the receptors at this activated state. Once bound onto the receptors, they internalize into the cell, causing activation of certain cellular functions. JR11, however, is an antagonist, so it binds onto the cell surface, but it doesn't actually internalize into the cell. However, studies have shown that it can provide much higher tumor to normal tissue uptake ratios, and that is because the antagonist can bind onto more receptor sites, regardless of whether the receptors are activated or not. It also has a potential theranostic use because JR11 can be labeled with an imaging radionuclide like gallium for diagnostic purposes, or it can be labeled with lutetium for therapeutic purposes too. So this is really a slide just showing you that JR11 has higher affinity to somatostatin receptor type 2 compared to dotatate. Preclinical in vivo findings showing that JR11 can be labeled with gallium for diagnostic purposes, showing very good uptake compared to gallium dotatate. It can also be labeled with a therapeutic agent, lutetium. And in this in vivo study, it has shown that when labeled and treated with a therapeutic compound, there's about a 35% higher tumor uptake in favor of JR11. And there's also a higher tumor to kidney ratio as well in favor of the antagonist. So following that, there's been a small human pilot study using lutetium-labeled DOTA JR11 for treatment, showing very encouraging results with high tumor uptake and also favorable therapeutic responses. As you can see here, this patient 3 months after treatment resulting in favorable scintigraphic and morphologic response. And this example of this patient at 12 months after treatment, favorable response, particularly in the hepatic lesions. So at the moment, there is an international multi-center open-label single-arm study looking at the use of lutetium DOTA JR11 for neuroendocrine tumors, and I believe this trial that we're one of the sites that's participating in this will be restarted shortly. So just quickly on alpha emitters, there's a potential new radionuclide that can be used for therapeutic purposes, particularly actinium and bismuth. So bismuth have recently been labeled to DOTA TOC for treatment. Alpha emitters emits has a very high lead rate, emits very high energy within a short range in soft tissue. So it's extremely highly cytotoxic, ideally suitable for lesions that are very small, for example, like in a liver infiltrated pattern or bone marrow disease, potentially reducing side effects in normal tissues. But I think preliminary results are very, very encouraging, but we're still awaiting for more clinical data to see how we can apply this clinically. So in terms of combination treatment, although this is preclinical, I think PRRT combined with PARP1 inhibitors is quite promising for the future. So what PRRT does is it creates double-stranded DNA breaks, but actually most of the time it is only able to create single-stranded DNA breaks. When single-stranded DNA break happens, what happens within the body is the enzyme PARP1 comes in to try to repair this single-stranded DNA break. So a PARP1 inhibitor basically stops that process from happening. It stops the single-stranded DNA break from being repaired. So when the DNA tries to replicate, it actually induces double-stranded DNA breaks. So potentially the combination of PRRT plus PARP1 inhibitor may augment PRRT outcome by inducing more of this double-stranded DNA damage. So again, although these works are preclinical, results seem to be quite encouraging. This is a preclinical study that was just published recently, showing that the combined PRRT plus PARP1 inhibitor combination could be very effective. So this arm here, showing the combined treatment significantly lowered the number of tumor cells and when compared to lutetium dotatate alone. And what's interesting is that it actually completely blocked cell growth from day 3. PARP1 inhibitor can also enhance the PRRT-induced cell death. So when they measured apoptosis with cellular cultures, the combined treatment arm with lutetium dotatate plus PARP inhibitor significantly induces cell death as early as 3 days. PARP1 inhibitor can also increase the number of double-stranded DNA breaks. So when they measured that on cellular cultures, double-stranded breaks here, the combined arm increased the damage at all time points. More recently, there's been an in vivo study using mouse models, and this work was actually done here in Pediatric by Rod's preclinical team here. So the mouse models were actually given 2 cycles of treatment. And basically, the group that received the combined treatment with lutate plus PARP inhibitor had significant reduction in tumor volume compared to the group that was only administered lutate alone. So although these are only preclinical studies, results are very encouraging and interesting, and hopefully this will be translated to more clinical developments in the near future. So this is just a slide to show you that there are currently a number of active trials that's happening worldwide in relation to PRRT and NETs, which is very encouraging and also confirms the increasing interest of using PRRT in neuroendocrine malignancies. And for more details, you can go on to clinicaltrials.gov to get more details of these trials. And just in the last couple of slides, there are some other tumors that also express metastatin 2 receptors, in which PRRT may be useful for. But I think more clinical trials are needed to evaluate the role of PRRT in these fields. However, one potential area, which I think PRRT may be very useful for, is to treat pediatric metastatic neuroblastoma. It's a very difficult condition to treat. Once the condition relapses, the prognosis for the patient is usually very poor. But a high proportion of these patients actually express metastatin 2 receptors as well. So this little boy actually came through our department a couple of years ago, unfortunately developed widespread multifocal metastatic disease despite all lines of treatment. As you can see, there's a exophyting and growing mass coming out from his skull, and it was very painful. And because of the high somatostatin receptor expression, he was given lutetium treatment with oral chemotherapy as a radiosensitizer on compassionate grounds. And 3 months after treatment, you can see a dramatic response there. He became totally asymptomatic, went back to school, became fully functional. And this was actually sustained at least up to 11 months. And as far as I know, he's still alive and well. Another group of patients who may benefit from PRRT is refractory pheochromocytoma. When pheochromocytoma is functional, it's usually associated with very difficult to treat hypertension, and which could be life-threatening as well. So this patient had a recurrence in the upper abdomen with metastatic disease in the mediastinum. And at presentation, you can see the catecholamine levels were significantly elevated, hypertension, and it was very difficult to treat. So he subsequently received PRRT, and over a period of time, there's been a significant morphologic response on scanning criteria. But I think more importantly, his catecholamine levels have significantly dropped since the PRRT treatment, and it was actually very durable for a few years, where he remained normotensive, he was off all medications, and he was able to do everything functionally and retained a very, very good quality of life. And I believe there's an upcoming clinical trial using Lutathera for this group of patients that's coming up shortly. So last but not the least, peptide receptor chemoradionuclide therapy may also be useful for a subgroup of patients with small cell carcinoma. So small cell carcinoma, again, very aggressive type of malignancy. Prognosis is usually very poor, but a subgroup of them may actually express metastatin 2 expression. This is a preclinical study, again, performed by the preclinical team here in Pediatric, using a mouse model with lung malignancy with high somatostatin receptor uptake. So they randomized these mouse to having either lutetium alone, chemotherapy, or combined PRRT plus chemotherapy, showing that the green line here, which is a combined arm, have a significant reduction of tumor volume and also significant improvement of median overall survival. So based on that, PRCRT was actually given to a patient with metastatic small cell carcinoma from the cervix. This patient was actually treated a couple of years ago. At the time when these scans were done, the patient was actually really ill in intensive care unit, pretty much pre-terminal. Widely metastatic disease despite all treatments available. So she was basically told that she doesn't have much longer to live, but based on the very high somatostatin receptor expression on the GAT8 scan, she was given PRRT on compassionate grounds. And I think the images speak for themselves. 2 cycles of PRRT plus etoposide, a near complete response on the images. This patient was discharged from hospital shortly after commencement of PRRT, regained a very, very good quality of life, and I believe she actually also attended her daughter's wedding as well, which she thought she wasn't able to. And however, the disease did come back at 4.5 months after initiation of treatment, but no doubt that the treatment has prolonged her life and also improved her quality as well for that duration of time. And at the moment, there's a cassette trial that's running in Pediatric looking at the use of PRRT plus chemotherapy in patients with metastatic small cell lung cancer. So to conclude, I think PRRT is now quite well established in many parts of the world for treatment of somatostatin receptor positive NET. But I think a more personalized approach tailored to tumor and patient characteristics can likely further improve outcomes. There are promising developments in both preclinical and clinical areas, including novel traces with symmetry and theranostic applications, the use of new peptide binding, and possibly combination treatments as well. But I must stress that a multidisciplinary team of experts are really required to turn research to clinic, and they're not listed in any particular orders. In the era of sort of multiple treatment modality and choices now being available, I think doing prospective clinical trials are really required, and some are certainly underway. But the ultimate goal really is to improve clinical outcome in patients with NETs and also other somatostatin receptor positive malignancies. So thank you very much for your attention.